Hello. No, start. Okay, thank you very much, all delegates and participants. Offline, one, online person. Today's 29th July, third day of the International Youth Conference. Now, our next session, session number 9, social security and social welfare scheme for workers living with HIV. So today is our two sessions. Mr. Syed from Geneva, and second is Mr. Jogendra, Patel, project director of the Arcaded and Report Gujarat facilitator. Let's start social security and social welfare scheme for workers living with HIV. So may I request to Mr. Syed, Mohammad, Afsar, from Tiger of Geneva, please start your presentation. Thank you very much. Providing treatment. Then you have treatment, you need nutrition. Yes, treatment all their even before the input. The point is, why does it matter? It has some steps of protection, visiting means of the area, the existing social protection policy, so that we put out more sustainable options and organize look there. And this only because HIV was the rate they are. And as you see, the breaking scheme and cybersecurity schemes are essentially aimed at taking care of the poor, that they will safety net, fall back in and to live their lives. Anyway, we have seen that social protection means that and forms or people with HIV as well as we did a study in the few years back where we tried to look at the access and effects of social protection on workers living with HIV, and we found that those workers who had access to social protection, in their case, treatment and monitoring very well, and they were able to take care of their families very well, children in school. So overall, they give like much better and much more about the course of their like that where so of course have mostly much of exchanges in terms of education and therefore it's supposed to HIV prevention and HIV social protection is not just people who are the stop HIV but also being more affected to their lives. I know we have two main instruments. Regulation to it talks about measures to society that do not including those related to the education, social protection, also reducing the link between health policies and development policies and social protection. The three need to come together in order to have programs. For social protection, I will has a recommendation for social protection program, which also have the sanity of personal discrimination means which includes slowly that industries need to give this discrimination. What are the core elements of HIV sensitive social protection in this discussion? Number one, at the policy level, the idea is to integrate HIV into national social protection policies and programs. So there may be a social health insurance policy, there may be an unemployment benefit policy, there may be a labor department policy meant for workers, and we need to see to what extent it includes HIV. If not, sometimes it's a very small intervention that is needed to look at the conditionalities which are part of the policy. Once you remove those conditionalities, people start accessing those services. Then we also have social safety nets program, like we have seen the cash transfers being done to poor families. If they also include people living with HIV and their families, it helps a lot. Keeping children in school, reduces the vulnerability of young girls to HIV, which has been demonstrated in several countries. So there are cash transfers, vouchers, food support, and school assistance. Those social safety net programs need to be reviewed and seen through the angle of HIV and see to what extent they are covering the source of HIV. If not, we should try to do advocacy for enhanced coverage. If we also see there are health and social services such as health insurance, nutrition programs, psychosocial support programs, which should also be extended to cover people living with HIV. And there are programs for livelihood and economic empowerment, whereby we go to people, strengthen their skills for business, setting up their enterprises, enhancing their employability, providing them bank loans, microfinance to help them set up their businesses and enhance their economic status. Those programs should also include HIV. And finally, but not the least, is that there are programs on human rights protection and social inclusion. They should look at HIV because sometimes because of stigma and discrimination, people living with HIV do not have access to those programs. So we need to make sure that the programs which are meant for inclusion do not exclude this important group of people living with HIV, which, by the way, nobody is 41 million, as we know. So there are some good examples which are already happening of integrating HIV in existing programs. For example, in Cambodia, they have included people living with HIV in their in their poverty, national poverty identification program, under which they register people and then they give them a card. Once that card called equity card is given, they start accessing cash transfers and food assistance, lot of health benefits, insurance, as well as education support for families. This has shown very positive impact on the lives of people living with HIV. India has made great strides in integrating people living with HIV in government schemes, which are meant for welfare, which are meant for um, support to poor families, to vulnerable populations. They include access to pensions, food assistance, educational assistance, and livelihood programs. And they're also, when this was happening, we looked at the conditionality, and sometimes we found that, for example, in a pension program, there was a government scheme called widow pension scheme in India, but there the eligibility was 35 years of age. And we realized that average age at which women living with HIV or women of HIV affected households were getting widowed was much lower. Average age was 29 years. So we used that study and made a case with the government that why do you have this education with this kind of age-related conditionality in a widow pension program. So they removed it because they thought it doesn't make sense. And so women living with HIV who got widow, women living whose husbands had died of HIV, they started accessing the pension. Similarly, there are programs of Labor Department, Labor Welfare Department, who have a number of very good schemes for different types of workers, construction workers, for welding workers, for um, workers who are kind of peculiar health workers, etc. And we need to do mapping of those schemes and inform people who with HIV about those schemes so that they start registering them in them. For example, the scheme from Gujarat, excuse me, we got a construction worker who was living with HIV. Part of this scheme who got a card made from the welfare department, and as a result of that, he could access the loan at a very concessional rate and made his own house to have a good house for himself. There are other examples coming from Kenya where cash transfers for orphans and vulnerable children is happening. In Thailand, there's health insurance access for migrant workers which have been extended to HIV. In Uruguay and Brazil, there are programs meant to extend social insurance to low-income and self-employed workers, as you see. So this is also happening. So there are schemes at the government level which do provide a lot of very useful support to people who are poor, or people who are vulnerable, who are disadvantaged, or marginalized. Now we need to see that how could we make sure that those schemes start getting to the households of people living with HIV. And with these examples, it's clear that it's possible to do so. Now, the global AIDS strategy that we have, very ambitious targets are there, but targets are not just linked to treatment and testing and prevention, but there are also targets which are talking about people-centered and rights-based approaches. Uh, and the most important point here is reduce inequalities, because there are inequalities that are driving HIV vulnerability, and inequalities are related to economic status, related to stigma, related to exclusion, and we need to find ways of being more inclusive in our responses. And therefore, the Global AIDS strategy is strongly recommending that we integrate HIV into not just health, but social welfare and community systems. We are also talking about employer-based support programs in India that extend to workers, and we need to make sure that the employer's insurance also covers HIV, or at least try their best to ensure that workers are not really devoid of support from the employer. And the most important support from the employer can be right to work. People should not lose their jobs because of HIV, because if they lose their job, they will die much faster than they would have died with HIV. Work is very important for all of us. So we're talking about strengthening sustainable national responses to these measures, and at the same time expanding protection and security for vulnerable populations, which are, by the way, not just people with HIV. Under the SDGs, the idea is to identify which populations are being left behind and map them, where they are, where do they live, what are the reasons that stop them from accessing government schemes and programs, and then try to address those reasons, those bottlenecks, and then support them and listen to them, bring them to the discussion table so that programs become much more exclusive. So these are some of the examples I briefly attempted to mention, and I will conclude by saying that we are in a situation that um, AIDS response is calling us to bring AIDS response optimization. It cannot be just given as a medical development program. It got to go to the spheres of health, uh, into the spheres of social support, into this spheres of social protection, into this sphere of employment support. And if that happens, the program will be much more sustainable, and at the end of the day, that will be the real people's. So thank you, and I hope this will lead to some discussions. And I wish I was there in person to take some questions, but I do hope that you will hear the endless explore answers. But at least go back. This is the idea of which help you in strengthening social protection, finding social protection to people living with HIV and families and friends. Thank you very much.
Hello, hello, hello. Thank you very much, sir. Syed Mohammad. Sir. Syed Geneva. Then next speaker is Mr. Jogendra Upadhyay from Gujarat, India. Gujarat AIDS Awareness and Prevention. Gap ISRCDE. Who is Mr. Jogendra Upadhyay.
Bonjour, Rio de Janeiro. Good morning, delegates, and leader, LHIV, and scientists. Myself, Jogendra Upadhyay. I from Gujarat Examination as a project director. Today, I share my experience and for hidden high risk population number. This is one of the rich and uncertain in the context of reaching criminal and life, we need to rethink how to reach hidden high risk MSN, PG, FSW, who are unserved in the migrant, mobile, and informal sector. But the obesity at the workplace project supported by international organizations in which GAP also work with the work with this hidden high risk group in 80s of the state in found that approximately 1% of sexual minority group responded in our initial survey. Approximately 2.5% disclosed sexuality to us during the stigma and discrimination free intervention. Our strategic intervention is a scope for maintaining the confidentiality and all the national AIDS control program guidelines. The hidden group has negligible income, very low information. Always not about it. And it's no fund of availability at the company and at the shelter. They are they are not registered with the main targeted intervention services run by state and control society. Have been tested for the HIV for the first time. And most of their sexual partners were their co-workers. The HIV screening program conducted by their organization with the workers revealed that 141 workers were newly diagnosed with HIV, of which 8 workers, 5.67%, were MSM. The reason for the increased risk and vulnerability in this student population is that most of them were they are migrant or local information workers, constantly change the workplace, company, town, rural, and city. And in one company, unfortunately, they are here inside. They are in one company, they are stigmatized by worker and others authority. In 2023 and 2, in our program, one worker was in our workplace at screening and workplace. Was cold storage in Gandhinagar district, Gujarat. He was detected both infection, syphilis, and HIV. They was registered for ART at Gandhinagar ART Center, Gujarat State. Yes. And the STI clinic at Gandhinagar. We provide the good counseling, we provide the good environment, stigma free, and stigma discrimination free talk, and also working to keeping the adherence. Therapy and conflict escalating. Services or social security services by government. I storage in a 2 years. Good. Also, job rate for the big teacher. And once in a year, at a Diwali time, I go to my native country. Stop on that time. And needs to rethink and rebuild strategy. Then mobile markets. The policymaker, the scientists, the request. There is an urgent need to rebuild and devise a strategy of prevention, testing, and treatment for the mobile key population and guys are unserved population. That is urgent need. But thank you very much.
Thank you. Upadhyay. Most important for the policy. Very important social protection scheme, social security scheme. Advance our council advice that social security and social welfare scheme. So, in the first session, session 9 is great. And second session is will start 1:30 on ethics, and explanation. It's scheduled. Thank you very much.